If you're using Kyprolis or carfilzomib at relapse, what dosing schedule are you using?
So for the most part, I use it in combination. So, certainly at the minimum, we go to 36. The real question, I think, right now is go up to the weekly schedule versus the biweekly, and perhaps we can talk a little bit more about that.
There was a clinical trial called Arrow that examined that.
The data was very convincing, with some comments to be made that weekly schedule so I will maybe summarize the study. Evaluated efficacy of weekly 70 milligram per square meter carfilzomib, which is double 36 in a way, versus twice weekly traditional approved combination, both with DEX. And that was eventually evaluated in a relapse setting, so doublet. And surprisingly, outcome was better for weekly, which to some extent, on a very superficial way, have indicated maybe weekly is better than twice weekly. But
have you moved to weekly then throughout?
I have for the most part. Although I have to say that the jury is still out in regard to how to do that, because when you push weekly to 70, which is what we think in combination is probably the right dose, 36 times 2, then you're getting to maybe a little bit slightly higher rate of cardiovascular toxicities, and that's the balance which we need to find.
Would you use 70 weekly even in combination, or would you use 56 weekly in combination?
I have trials when I'm using 70 weekly in combination with KRD and antibody, which I think is ongoing, so I have too early to really discuss it. I think that the field, it appears to me, is going to be moving to 56 in combination weekly.
So Andre, when you talk about cardiac toxicity, are you talking about the subtle changes, or are you talking the more serious one? Because the Arrow study did show very similar toxicity, right? I think the Champion originally had brought up some concerns with the Champion was the first study of once a week carfilzomib. But I think this is important information because I see myself moving to weekly. So is it the more serious one that you're concerned, or the subtle changes you were describing?
Well, maybe I am repeating what is being reported to us rather than from experience, and I agree. Arrow study actually showed no difference in toxicity with even higher dose of total dose of carfilzomib. Single agent. And in combination, it is it has been a concern from some of the emerging data and studies that with 70 combined with in triplets with, for example, lenalidomide and dex, 70 may be one level dose too high, and I don't know enough to really comment in more specific ways. I'm actually comfortable using 70 in triplets and quadruplets, but I think that is something which needs to be continuously watched.
Yeah, I think I'm a little uncomfortable going that high in combination therapy. What about you, Rafael?
Yeah, I do have the discomfort too. I want to see a little bit more data. I think it depends on the myeloma. I think, if the person is a slow relapse or there's not an aggressive disease, I think it's probably better to err a little bit on the lower side on safety. Which by the way, I was going to say, if there's any community provider that is hearing us, I've seen circumstances where patients have stayed on 20 forever, and that is just because everyone leads a busy life, and the orders were there, and there was no switch to either at the minimum 27, 36, and so I've seen a few patients like that. And I think it's important.
There's a law of still 2027 because that's the FDA label.
Right,
yes.
right.
So,
but I think there is some merit in this slightly higher doses of the carfilzomib as long as they're well tolerated.
But if you have treatment plan which is extended, which includes carfilzomib, then potentially moving to weekly is almost a must thing to do. There is no way that you can continue twice weekly for many months, forever.
Do you give it every week or 3 out of 4 weeks?
3 out of 4.
I'd like to give every week, but our orders. It's too complicated.
I override them. I do it every week.
You have to teach me how to do that. Any cost implications of going weekly, or is it pretty much end up being the same?
Well, you're going to have less infusional cost. I mean, from a payer perspective, less visits, potentially a little bit less laboratory, right? So, and from a patient perspective, which one of the aspects of the cost considerations is that it's not only the patient, but it's the caregiver. So if someone has to drive you to the clinic, it's going to take a half a day off of work. So many of them are going to have to take the full day of work. So it's 2 days of lost wages versus one.
So that's a very good point. The drug costs the same once weekly, but all the other
Right.
benefits
there's
of
going to be a
Sure.
lot of
less
benefits
visits,
downstream.
less time off work,
Right.
it
And
makes
just
it
more convenience, and greater for
Outside of
patients.
clinical trial, if patient has been long on twice weekly schedule, say 27, we pretty much move all of these patients to weekly schedule at 56, which is the same dose but weekly. For those who are on 36, I have discussion whether it's right thing to do, and we sometimes test the waters and select the best tolerated dose.
What are you hearing from patients taking carfilzomib? Are you hearing a lot of people, are they happy with it? Are they unhappy with it?
I think people understand that it's a very effective therapy, which they like, and certainly everyone is very happy that the schedule is moving to once weekly, and that's just great news for patients because there's no change in the efficacy, but it's certainly much more convenient for them, and for many of the reasons that Raphael mentioned too.
And if we're going to give it in combination with daratumumab, do you give it the same day? Just yes or no?
Yes.
Yep.
Same day? Okay. And so you're not hearing much people calling in saying they've had significant toxicity from it?
No, but we have actually had people say that they're very interested in that drug because of the neuropathy of the alternative, right?